Welcome, friends. This is Dr. Jaitly on your favorite site, Muni Health, which is showing on several social platforms as video vignettes and channels. So welcome again. This is Dr. Jaitly from New York, your cardiologist on Muni Health. Thank you for watching Muni Health, where medical education primarily and the patient education both are very important to improve our clinical outcomes, and that's one of the things that's clearly shown by several studies, as well as at NIH in the US, where several studies have clearly shown that the clinical outcomes or the clinical patterns much are different if the medical education is combined with patient education together. So welcome again to Muni Health. Without any further ado, I like to delve into the subject matter. We are using Wacom 2 as a new drawing board, as you must have seen now, and we are making progress slowly into our armamentarium for our studio capabilities here. So just so that you know, on this one, by the way, in this videotape, I'm going to be talking to you about the ECG. Now, in fact, this was suggested by some of my, very, very close medical students who are watching on Muni Health. And somebody asked me, why don't you do a video, Dr. Jaitly, on a simple ECG where you define how to measure the heart rate, what are the things to look for in a small strip. So we'll try to cover that in a very, very short manner here. But again, it's not an exhaustive ECG review, but, just a supplement to your review that you normally are required to do as part of your curriculum. So look at it. When you do an ECG, obviously you'll see a normal complex first, okay, in a normal individual. So you'll have a P wave. What is a normal complex? It consists of a P wave and a tiny little Q wave, and then an R wave, and then a deep S wave, and then a T wave, which is upright, and a U wave. So there's an upright and a downward, upright and an inverted wave, and an upright, and then again followed by. Now U waves sometimes may not be seen because specifically it's seen only in a where you have your heart rate is kind of slow, like 50, 40, etc., where there's enough time for the U to really reflect on the isoelectric line. This is called the isoelectric line, by the way, between one complex and the other. Now each electrical complex represents a cardiac cycle, just so that you know. So a lot of people ask me, for medical students, it's very important. So what am I seeing on an EKG? Well, you're seeing your cardiac cycles in an electrocardiographic signals as they are represented on the EKG paper. Now remember, the EKG paper does not run at its own speed. It runs at a set speed, and because it runs at a set speed of say 1500 boxes. Now I'll tell you what those boxes are. Now when you look at the EKG paper, for instance, say this is your strip, okay, so it has tiny little boxes, and these are heavy lines, then again another box, and this is a heavy line, then another box and a heavy line, and then another box and a heavy line. So this is what your EKG paper consists of, like, and similarly we have boxes here, similarly we have boxes here, but there are heavy lines in between. And in between the heavy lines there are 5 boxes, just so that you know. So 5 boxes which are equally spaced, 1, 2, 3, and then a 4, and that makes it 5. 1, 2, 3, 4, 5. So there are 5 small boxes, and this is one line. 5 small boxes again, and there'll be a second line, a third line, and so on and so forth. So the EKG paper really contains about several of these small boxes and then a heavy lines, 5 boxes and a heavy line, and the EKG paper normally runs on your cardiogram machine 1500 boxes. Remember, these are 5 small boxes. So in other words, how many boxes will it run? It'll run 100 heavy lines. So 1, 2, 3, 4, 5. It'll run 100 heavy lines and 60 seconds. So that means 1500 boxes would pass through once. If you mark it at some place on the EKG paper, 1500 boxes would have lapsed or would have passed during those 60-second period. Now, it's very important to know because that's how you'll calculate the heart rate. Now, many times, the computer will print out and give you the heart rate, but that's an easy part. I think this is for the medical students to know that it's very important how you calculate the heart rate. So 1500 boxes, and now we have an electrical complex which was just completed here, PQRST. Then there was an isoelectric line. Then you have another complex that comes up here. That's your second heartbeat. Now, the best is to measure the RR interval. You could measure PP interval, but PP is very small. Q is even smaller. You could measure SS interval. That's fine. But conventionally, we all call RR interval. And when you measure RR interval, because normally R is the tallest the tallest waves in the whole PQRST, complex, RR intervals should be measured, and count the number of small boxes that have occurred between the RR interval. Say if the RR interval has 15 boxes in between this R and this R. So to calculate the heart rate, what you do is 1500, which we know is the total amount that will traverse in 60 seconds, divided by 15, because you just measured 15 small boxes. That gives you a heart rate of 100 right there. So it gives you a heart rate of 100. Now, if you have 20 boxes here in between, you will have a heart rate of about 75. And then likewise, if you have 30 boxes, that means the RR interval is occurring at a later time. Your heart rate will obviously drop and it'll be 50. So, and so on and so forth. So you can calculate this very, very easily. Use a calculator if you like. But the magic number is 1500 divided by the number of boxes. Number of small boxes, remember, number of small boxes that you look at on the EKG, and that'll give you the heart rate. Done. Very simple. Okay, now move on to the rhythm. So first define whether the rhythm is regular. If the rhythm is regular, it could be normal sinus rhythm, which we call as a normal beat, or it could be an SVT, supraventricular tachycardia. Now that's beyond the scope of this video presentation. We've done a different presentation for SVT, but I'm just giving you an example. So, or it could be an atrial flutter. Atrial flutter is also very regular. Okay, so these are your regular rhythms, examples of regular rhythms. Irregular rhythms are again divided into one, which is regularly irregular, and the second one is irregularly irregular. Now, regularly irregular implies that there is a beat, and then it's irregular. That means it could be a VPC. It's called say a trigeminy. So if there is a trigeminy, that's a classic example where you have a normal beat, and then you have a VPC, for instance. So that's regularly irregular. And some of them, they could be irregular. Example is classically atrial fibrillation, where the RR interval is coming at random pace. You can have an R here, and then an R here, and then an R here, R here. And then see how irregular the whole rhythm can be on these EKGs as you print out. So, so irregularly irregular, the classic example is atrial fibrillation. Next, what you do is, so you've measured the heart rate, you measure the rhythm, next you measure is the axis. Axis, obviously, normal axis is anywhere between -30 to 110. Okay, anything over 110 is considered as right axis deviation. Anything less than 130 is considered as LAD, or left axis deviation. So you just need to know, and then there is an Einthoven's triangle that you have to really memorize. That's beyond the scope of this video right now, but again, make sure you go back to the syllabus, look at the Einthoven's triangle, and then try to understand how you measure the axis. Again, you have to look at the most isoelectric complex out of the EKG, and then actually look at and see what's the best way to look at your axis. But the key is that you don't need to worry about the axis between -30 and +110, because that's normal axis. It's only the left axis and the right axis, or a change of axis. I always say a change of axis is important. Okay, and we'll discuss that later. Configurations, P waves. You need to see if they are P mitral, like in a mitral stenosis or mitral regurgitation, large left atriums. When you have a left atrium which is very, very large, you will expect the P mitral to occur, and that is about 2 boxes up and 2 boxes down. So the P wave that we are just talking about here, that P wave is either 2 boxes up and 2 boxes down. That's almost like a 4 square millimeter. So just so that you know, for 4 square millimeter, you can have a P mitral by definition. Your QRS, when the QRS is more than 0.12 seconds, that's considered as a bundle branch block. Remember, between 0.09 to 0.11 is incomplete bundle or IVCD. Now, when you say 0.12 seconds, that means it's implying 3 small boxes. Remember, each box is about 0.04 seconds if you were to calculate. So 0.4, so 3 boxes in between would be about 0.12. And anything more than 0.12, 3 boxes, more than 3 boxes, that will give you a white QRS complex. And of course, if it's less than the 2 boxes, 1 and 2 boxes here, which is the normal, so that's about 0.08 second, and therefore you look at a normal QRS complex only. PR interval, very important. PR interval should be about 0.12 and again 2.2 seconds roughly. What is the PR? That's the onset of the P wave right here to the onset of R wave, which is right here. Now, normally Qs is seen, but Qs may not be seen, but this is your PR interval right here. Okay, so PR interval is very short, but just remember that it should be within 0.12 to 0.2 seconds is the allowance. Anything more than 0.2 0.21 is considered as borderline first degree AV block. Don't worry about it. But 0.22 is more than 0.22 here. This is my misprint. More than 0.22 will give you a first degree AV block. And 0.12 or less will give you a pre-excitation. That means the heart, there is AV conduction is going rather too fast between the atria and the ventricles, just so that you know. And we'll talk about pre-excitation, I have talked on a different video. Quickly summarizing ST depression or ST elevation. So there could be changes of two types in the ST segments. These are your ST segments right here, because STS ends here and this becomes your T wave. So if the ST segment is depressed, then what it looks like is the PQRST and PQRST, and then this is your ST and then a T wave. So the ST is depressed. But then if you have an elevation, it'll look like this. And a T wave. So this is an elevation and this is a depression. So that's called an ST elevation, and this is an ST depression, if you will. So ST depression is below 1 millimeter is considered as below 1 millimeter is considered as ischemia, and ST elevation more than 1 millimeter is considered as infarct. So having defined all of that, the T waves. Now T waves could be flat, they could be inverted, or they could be tented. A flat T wave normally is considered as non-specific, or it could be ischemic. An inverted T wave is always ischemic, unless proven otherwise, and especially a change in T wave configuration. Now sometimes, very rarely, because of the huge respiratory variations, like soon after an exercise, if you were to do certain T waves specifically in the inferior leads, they could be inverted, just so that you know. And a tented T wave normally means that the potassium is very high, and sometimes they are hyperacute because of either ischemia or an infarct. So it could be either. They could manifest either ischemia or infarct. Sorry about that little scribble there. But ischemia and infarct could also be a cause of the tented T wave. Well, that's all, folks, on this within the video vignette. Again, as I said, this is not a syllabus. This is your supplement to your syllabus. If you're having an emergency, you must go to the hospital and treat yourself, or call the ambulance and get to the hospital rather quick. Call your doctor. And again, as I said, this is purely a medical education and a patient education channel, or a video vignette only. Okay, thanks for watching Muni Meter Health. I appreciate your time, and of course, please spread out the word and tell your doctor colleagues and your students and your medical fraternity that Muni Meter Health is one which is dedicated to improve the clinical outcomes by improving both. Thank you so much again.